out into the ether, out into people's world. So I've got to sit down and speak to you this afternoon. We have 2 hours together to look at all things related to complex child trauma recovery, right? Childhood abuse, so complex trauma recovery, complex PTSD, adult survivors of child abuse. Whichever language you like to think about, that's what we're going to look at in the next 2 hours. I'm going to share a little bit about myself and a little bit about what my background is in a minute, but then I'm going to introduce you all to a whole bunch of different authors and people that quite often come to Australia and do presentations in the complex trauma realm in the field, and see what they have to say, see what we can learn from them, see what are the efficient ways of promoting change when matters are very complex. So I have a whole bunch of slides. It's going to be quite a roll through of slides as we go along. It's interesting how that's coming out. It's different on my computer, how it is here on the screen. Rod has already said that we are welcoming and acknowledging people to country. So I wish to welcome Aboriginal peoples, Torres Strait Islander peoples, people of Yuin Nation and South Coast people, other Aboriginal people and Torres Strait Islanders who may be tuning in from different areas around Australia. I myself work on Gadigal country. I'm up in Sydney. A little bit about myself. That's a little bit about my background there. Mostly I started work in 1990. So prior to 1990 I was working in agriculture. 1990 I slipped over into mental health work. Drug and alcohol work was a big part of my work. Gestalt therapy was the first method of therapy I learned, along with the drug and alcohol counselling. And then after a couple of years at the Illawarra Gestalt Centre with Michael O'Neill, if anyone remembers Michael O'Neill, I went across to the Hakomi therapy people. And they were the guys that really helped me work with complex trauma, the Hakomi people, because they brought mindfulness into therapy back in the 80s. Before it became a big thing post-2000, these guys were using mindfulness and were very, very clever in their use of mindfulness. And I'll talk to you about that as we go along. So Hakomi therapy, sensory motor psychotherapy is also in my background. I'm a registered psychologist, so I've done study at the University of Auckland. That's where I did my undergraduate and postgraduate at Western Sydney. Bits and pieces of my background. I work mostly in the addictions field, drug, alcohol, gambling, and of course in that field with lots of people in and out of jail. So very close to the forensic side of things as well. And everybody since day dot for me was a complex trauma survivor. Horrible child abuse history. So that's a bit of my background. Colin Ross is there. Trauma model therapy is there on the side. That's another part of the work that I've done. Now, complex trauma, of course, we start to look at all things beyond PTSD. So we have PTSD, but then we have all things beyond that. All things from childhood, emotional neglect, war exposure, terrorism, forced migration, persecution, country of origin, of course sexual assault, sexual abuse, exposure to a pedophile, physical abuse, witnessing rape, witnessing assault, especially of women and mothers, emotional abuse, educational neglect, physical and medical neglect as well. And complex trauma means that this pattern of abuse happens over and 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 over. So it's not just one-off sort of exposure. It's exposure for weeks, months, years, maybe decades in some people's lives. So we have this notion of prolonged developmentally adverse exposure. Quite often of an interpersonal nature. It's not a bushfire, it's not a tsunami, it's not an earthquake that's traumatized our clients with complex issues. It's other people, mainly carers, older brothers, older sisters, mums and dads, carers of children, teachers, priests, nuns, brothers, scoutmasters, etc., etc. So have a whole bunch of interpersonal trauma from people close to the family and close to the children. I'm going to keep rolling through. Recovery, in some regards, seems to be all about, well, we must expose people, we must get them back in touch with their trauma history, their trauma dynamics, so that we can process that. So it seems like, in some ways, that complex trauma work will be a lot of exposure work to a lot of pain, a lot of suffering. But that's only half the picture. It's not all about pain. But yes, I do have about 4 boxes of tissues in my counselling room. So there's pretty much everywhere you turn, you can pick up a tissue. And people do go through the tissues. There's a lot of grief, there's a lot of loss, there's a lot of sadness, there's a lot of what people never had, there's a lot of trauma to debrief. But also there's a lot of play to be had, because children who are surviving complex trauma never got to play. They never got to have fun. They never got to explore. They never got to be free. So there's a whole bunch of other playful exploration, fun, enjoyment. That's a big part of complex trauma recovery. It's a big part of our work with people. So it's not all about pain. Pain is 50-50. Half the time we're facilitating processes related to enjoyment or peacefulness, some sort of time out, some sort of respite. So don't think it's all about pain, even though you should have plenty of tissues in your room close by when working with people. Okay. I'm going to give you a little quote from the Reverend Robert Taylor, 1831. He says, "For God hath made me what none of them are, an able minister of the New Testament, not of the letter, but of the Spirit. For the letter killeth, that is, you see, it makes fools of people, but the Spirit giveth life." That is, there's some good fun. Again, we're back to fun. Good fun and work for science in it. So what I'm going to talk to you about today is the experience of people's rather than the textbook. Okay? My experience as a clinician, my client's experience of therapy, my client's experience of complex trauma and trauma recovery. And when we get into complex trauma and empiricism, we're not at random, controlled, blind trials, because you can't do that with people in crisis, people who want to kill themselves. You must offer them treatment. You can't put them in a control group and some in a treatment group. You must treat everybody. So the empirical evidence comes down the list, and it becomes the evidence of expert opinion. So all of the guys around the world, the US, the UK, other places, the experts in the field are clinicians who've worked for 30 or 40 years and written books, and it's their professional expertise, professional opinion. If it works, you keep going. If it doesn't, you change. So we're getting change that's happened. I don't know if you guys saw this, but in, say, 1995 to 2000, 2005, that 10-year period, the trauma field was really starting to do international conferences and international presentations and workshops. So it seemed like from the mid-90s and beyond, everyone started to talk about trauma, and now, of course, complex trauma and so on. Now, usually there'll be 2 days in a presentation, say from someone from America like John Briere, and they tell us all about what is trauma and how does it impact people. So what's the impact on the nervous system, on the body, on the mind, on development, and so on and so on. So day one, circa 1995, is the same as day one, circa 2023. What is trauma? It's the same stuff. But day two is, well, what do you do with that? Now, back in the day, it was all, well, you do some sort of cognitive behavioural therapy. Some sort of Wolpe, Joseph Wolpe, exposure technique. And so EMDR is one of those methods, and other exposure methods of therapy. And you see that the complex trauma field was promoting that from about 1995 to about 2005. But from about 2005 and beyond, it's all been promotion of mindfulness. You don't hear people claiming CBT as the way to go forward, except academics. People in the field who are working with clients all talk about mindfulness, and they talk about mindful somatics. What is mindful somatics? What does that mean? What is a somatic therapy? What's that mean when you're doing? Yeah, Amy's here in the room. She's saying it's mindfulness of the body, consciousness of the body, awareness of the body, paying attention to the soma or paying attention to the nervous system. So a big part of trauma work is paying attention to this person's autonomic state. What is this person's autonomic state that's sitting in front of you? How aroused are they? How tense are they? How volcanic are they? Or how flaccid? How shut down? How collapsing are they? What's happening in their body? What's happening in their posture? What's happening in their somatic present self? How is their breath? How is their colour? How is their emotion? How is their state of being in their body? It's all the body-based stuff. So, most of the trauma field these days promotes some sort of movement-based, almost type, yoga-type therapy, especially for young people. Yeah, Bessel van der Kolk, who's a big person in the trauma field, came from the trauma centre in Boston in the US, and they're one of the leading educators of trauma-informed yoga. Yeah? How to do movement-based, somatic-based, yoga-based, mindfulness-based movement stuff with people. Now, that's not going to be for all people, but that's going to be good for children, adolescents in particular, and some adults will benefit from being able to stretch and move and explore their somatic self. Now, having said this about somatic therapy, I'm a Hakomi therapist, but I don't do touch. So somatic stuff is, I notice something about you. To me, you seem really tense. Do you notice that? So you point out things about the other person. Hey, you seem to be racing in your mind. Do you notice that? Hey, you seem to be really tired right now. Do you notice that? And the reason I keep using do you notice that is because it's synonymous for mindfulness. I don't have to use the word mindfulness, just talk about stuff that we keep noticing. So paying attention to present moment, paying attention to the body, using the term noticing. Okay. Now, Colin Ross, I'm going to read through this because Colin Ross is a very interesting psychiatrist. And he wrote this book, The Trauma Model. Okay, so I'm going to read what's on the slide here. In 1979, he says, I did my clinical rotation in psychiatry as a medical student at the University of Alberta in Edmonton, Canada. I noticed then that the psychiatric inpatients tended to have many different diagnoses. They would be admitted and treated for depression on one occasion and for a psychotic disorder another time, and often they would have numerous admissions. The current diagnosis was always the correct one, but at some point in the future it would become a past incorrect diagnosis. I was most troubled when I saw the diagnosis changed several times in a single admission. Not uncommonly, the diagnosis was changed in order to provide a rationale for prescribing a new medication. Some psychiatrists were simply sloppy diagnosticians and irrational polypharmacists, but others were very careful and conscientious and reasonable. The problem was that the patients did not fit the conceptual system of the late 20th century or early 21st century psychiatry. Even when the conceptual system was applied consistently, it did not work. The patients were too polymorphous, variable, complicated, and often uncooperative. So, sorry guys, I get my change of slide, there it goes. I was taught that sometimes this is because the patient was borderline. Borderlines, I was taught, displayed pan-anxiety, pansexuality, polymorphous perversity. Those terms conveyed to me the frustration generated by the conceptual system. Even if the borderline patients were set aside, the problem persisted. On the inpatient words, the norm was extensive comorbidity. I've been thinking about this problem for 21 years and have devised a solution for it, which I call the trauma model. Okay? The purpose of this book, which is the book that we're looking at here, is to define the problem of comorbidity and then to describe its solution through the trauma model. The trauma model is a comprehensive, testable, scientific theory of mental illness. The polydiagnostic patient with extensive comorbidity is the major recipient of inpatient psychiatric treatment. In managed care terms, this is the high cost, high utilisation, high recidivism patient. There is no scientific model in psychiatry which accounts for this patient, even though he or she is the major consumer of psychiatric services. So the dominant model in contemporary psychiatry is the single gene, single disease model, which is the biogenetic sort of framework that medical people are taught. Insurance policies which have expanded their coverage for serious mental illnesses, including disorders assumed to be distinct genetic biomedical brain diseases within contemporary psychiatry, such as schizophrenia, unipolar and bipolar depression, obsessive-compulsive disorder, substance abuse, and so on. Yet the patient requires expensive psychiatric care and for the most part does not fit the single gene, single disease model. They meet DSM-4, DSM-5 these days criteria for many different disorders and are often given many different clinical diagnoses over time. The separate disease models simply cannot account for the clinical data. The problem of comorbidity, from a financial perspective, is the core clinical problem in psychiatry. So that's a psychiatrist saying that, who's been a psychiatrist all his professional life. And he's written very cogently and quite broadly about the limitations of the medical model with significant mental health matters. And the possibility of reframing how to work by looking at people through a trauma lens. Really focusing on the trauma side of things. So complex comorbidity starts to look like this.